Hi everyone, this is Neel Raithatha, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the WAXscope. And here we had a really complex case. It's of a young child who had really small ear canals, and therefore I'm using our smallest specular size, which is a 3.5mm diameter. When I first started using the WAXscope, I was actually using this specular size quite often, more often than not actually. However, my go-to specular size now is our medium size, which is a 4.25. And with this particular case, as we progress during the video, you'll see this lateral wax is more of a clay type of wax. I'm going to use some olive oil in a moment, I think, just to help bind it together to get a better suction grip. But very deep in the ear, this patient had crusted, really dark, dry, crusted wax adhered to the eardrum. So one of the questions we quite often get asked with the WAXscope is are you able to remove wax very deep in the ear? And the answer is yes, but obviously you need to be trained. And whenever you remove earwax off the eardrum, whether it's with a microscope or an endoscope, it always is a bit challenging because the deeper you go in the ear, the more sensitive the ear is. And of course, when you've got wax on the eardrum itself, it does require a high skill level to remove that. So I'm just slowly wriggling this out the ear. It's just got trapped near the entrance, so I'm just going to dilate the ear open a bit wider. And this is one of the advantages of the WAXscope over the endoscope, is when you've got someone with a really narrow ear canal entrance, you can use the specular to dilate it. Now, once you become comfortable with using the endoscope, that's no problem at all, but that's one of the most difficult things to teach actually, is when someone's got a really small ear canal entrance or even a collapsed canal at the entrance. It's difficult for specialists sometimes to dilate the ear with an endoscope, because with an endoscope you're actually using the endoscope itself and also the instrument to stretch the ear open. It would be great if everyone's ears were large and straight, but in reality that's not the case. And patients who have really small, narrow, bendy ear canals are more prone to developing wax, and that's because for the majority of us, I would say in the UK, I think there is some variation around the world, but in the UK at least, I would say about 90 to 95% of the population, the earwax naturally migrates out of the ear. We all more or less produce earwax, and earwax is self-cleansing, so the skin that lines the ear canal and the eardrum, as that dies and sheds, it moves sideways like a conveyor belt out of the ear. And in that process, it should transport any earwax sitting on the surface also out of the ear. But if you have a narrow, bendy ear canal, you can imagine that wax is going to get trapped as it's trying to migrate. And also, when you've got a smaller ear canal, your ear is probably more or less producing the same amount of wax, but because it's a smaller ear canal, it tends to build up quicker. So we removed the lateral wax, and I did use the Rycorette, but because of the consistency, although I did manage to get some of the wax out using the Rycorette, it did also spread some of this wax. It was like soft butter or jam on a slice of toast. Sorry if anyone's having their lunch or indeed their breakfast. So as you can see, I've just put some more medical grade olive oil spray, and what the olive oil does, if you've been watching my videos, you're probably fully aware, but anyone new to the channel, the olive oil tends to have a binding effect. It's almost like an egg in a potato cake or fish cake recipe. It binds the ingredients together, so it's a bit easier, it coagulates it almost, so it's easier to extract. And believe it or not, this patient has to attend every 4 months. They are a young patient and they do have a skin condition. They're not entirely sure what it is, but it could be eczema or psoriasis. And patients who have eczema or psoriasis or any skin condition really in the ear, they tend to secrete more wax, and that's because when you have eczema or psoriasis, you have underlying inflammation. So eczema is more to do if you have an allergy, so it could be to shampoos or other products that may unfortunately enter the ear, or if sometimes even food allergies. Whereas psoriasis is more of an autoimmune condition, but nonetheless, both of these conditions cause deep underlying inflammation in the ear, in the skin. And when you have inflammation, it means you have increased blood flow, and that as a consequence causes the ear to produce more skin cells, and the more skin cells you produce, naturally these skin cells are eventually going to die and shed. And the primary ingredient of earwax is actually dead skin. So in the Western cultures, majority of earwax is dead skin, around 60%. In the Far East, it's a higher concentration, it's probably 80 to 90%. And the other two ingredients is sebum, which is an oily lipid secretion secreted by the sebaceous glands, and the sebaceous glands are attached to the hair follicles, and they're not just exclusive to the ear, the other parts of the body as well, where you have hair growing. And sebum has a protective mechanism. It's acidic, so it helps to provide an acidic mantle. Now, in the ear, that's really, really important, because our ears are full of bacteria and fungi, but the bacteria are in the ear they don't cause infections under normal conditions. So when the ear is acidic, which the ear should be, these bacteria, this natural skin flora, these natural inhabitants, bacterial inhabitants, they don't cause a problem. But if the pH level increases and becomes more neutral, then it gives rise for the development and colonization of more neutrophilic bacteria, which are more pathogenic in the ear. And also the other ingredient of earwax is the hairs. You can see there's a few hairs here. So this is the wax that's stuck to the eardrum and in the anterior recess, and it's really dry and crusty, so I'm going to put some medical grade olive oil. And the other ingredient is emotional sweat secreted by modified sweat glands. They're called apocrine glands, and the ones in the ear have their own name. They're ceremonous glands, and we secrete this emotional sweat as part of the fight and flight response. And they all amalgamate to form earwax. So you can see I've just lifted that from the inferior and anterior recess. The oil really helped to soften it and also lubricate it against the eardrum so it comes away. So for someone who's had to have this done 4 months ago, you can see the rapid development of earwax, and it's quite dark as well, so it's oxidized. In the past, this patient's earwax is a bit more, just more like how it was laterally. It's a bit softer, and it's a bit more of a light orange, brown colour. So just some residual wax. I'm going to get it in focus, and I'm going to use the fine end suction probe. I tend to now use a 17 gauge suction probe, which I used to use an 18, but 17 is slightly larger. It's still small. I just feel it's more effective. There's a little bit left on the drum, but we're going to leave that. That's not going to cause the patient any problems. So if you are an ear specialist and you want to get trained using the WAXscope, please do email info@clearwax.co.uk, and I hope you enjoyed that video. Take care, guys. Bye.